Okay. So yeah, again, thanks everyone for planning this event and also for everyone who's joined. Today, I'm just going to give a pretty, I think, brief overview of CHIME, which was developed by my team at Penn. And in addition to that, I'm hoping to leave plenty of time for Q&A at the end. So if you have any questions, just post them in the chat, as Rama was saying, and I'll be sure to answer them, hopefully. So for those of you who maybe might not be familiar with this whole concept of flattening the curve, hopefully everyone's familiar with it, but I just want to briefly introduce this as a concept. So this red curve here represents what may have happened if there was no social distancing put in place to help prevent coronavirus infections. And the blue curve is what things might look like if with some social distancing measures or other measures to help prevent or slow the spread of infection. One kind of interesting thing that you can see in this graph is that in the case without any social distancing, the healthcare system might easily be pushed over its capacity. So for example, there might not be enough ICU beds for all the infected patients, or there might not be enough ventilators. And so the blue curve is a case where with social distancing, the healthcare system is no longer over capacity, but as you can see, it pushes out the length of the infection. So rather than being compressed into a very short time window with social distancing in place, we're now looking at a scenario where the infections happen much slower, and so the time window it's much larger. And so just very briefly, I want to discuss what are some of the kind of important things that we can predict from a data science perspective when it comes to the coronavirus pandemic. So obviously right now, what we're talking about with CHIME is predicting the hospital bed usage and ICU bed usage and ventilator utilization. Another area that our team, in conjunction with some researchers at Wharton, has been working on is projecting how much PPE, personal protective equipment, will be needed by staff, so that like masks and gloves and things like that. And then some other things that we're also looking into as far as the types of things that we can do from a data science perspective are predicting readiness for discharge, predicting which patients are have the highest need for ventilation, and maybe trying to take a more data-driven approach to patient triage. And then also something that's just been emerging recently, for example, is how to take a data-driven approach to determining when to start opening back up elective procedures. Okay, so next I kind of want to talk about how we're using CHIME right now, how it's being used by decision makers at Penn. So it's basically every day an analyst generates a daily report using the CHIME tool, and those reports are shared with the decision makers, and based on the reports that have been provided to the executives at Penn so far, they've taken a lot of actions. So they rushed the construction of a new hospital. They added, which would have added 100 extra beds capacity to the hospital system. They canceled elective surgeries, and they're using it to also stop taking transfers from other hospitals. They set up a new emergency triage, like ER, ED triage unit to deal with increased demand. They started working on personal protective equipment and ventilator conservation and acquisition. They expanded the ICU at the downtown hospitals. They considered doubling room capacity, so doubling up the number of patients in each room, and they reserved hotel rooms for staff around campus. And oh, that was interesting. Anyway, so there, like we actually have a paper which I'm going to link to at the end of the talk, which was published, and one kind of interesting quote that I think was paraphrasing some feedback that we got from the executive team was they said, "We anticipate that the epidemic insights gained from CHIME will save many lives by turning vague scenarios of overwhelming clinical demand into actionable estimates of strain, permitting our health system leaders to prepare, react, and respond." So, and then just very briefly, I want to kind of give you an idea of like what the information they were presenting to the executive team looked like. So this is actually like one of the slides that we presented that's being presented daily to the executive team. And so this is just like a general overview. It says the forecast, the number of and rate of COVID-19 cases and resulting hospitalizations, ICU stays, and ventilated patients. Use best estimates of current conditions, spread rates, intensity, and market size of Penn Medicine within the region. Customize standard CDC approach to epidemic dynamics to local context, and connect predictions to project potential system level impacts, and explore scenarios from best to worst case to guide planning after. So this is just like a high level overview. And then we also kind of in the slides dig into the assumptions that we make when these are basically, parameters that we're feeding into the models. So in this example, this is from March 20th. We were assuming a doubling time of 6 days, and I think it's being highlighted here because this actually changed since the previous time this presentation had been given, and a social distancing factor between 23 and 30%, because I think this is after social distancing had already started in Pennsylvania. And at that point, we were assuming a hospitalization rate of 5%, ICU care of 1.5% of overall infected patients, a recovery time of 2 weeks, and hospitalization, this is average length of stay, 8 days, and then for ICU patients, an average length of stay of 16 days. And one kind of other important aspect of this slide is just kind of all of the references to where we came up with this information. And then here's what the actual like output of the model at the time looked like for example, for a single hospital. And so basically in the upper left-hand corner, we have, let me actually split it up by left-hand side, right-hand side first. So the left-hand side is kind of like the low spread scenario. So that's like the best case scenario. And the right-hand side is the high spread or worst case scenario. And you can see in the top left, we're sort of showing, we're showing the, I believe this is the new admissions per day. Yep, and so we can see that they're increasing over time. By May 6th, we're looking at 8 new admissions per day. And then on the upper right, in the worst case scenario, we're looking at, for the same time period, 24 new admissions per day. And then on the bottom here, we have a look at what the model believes that the census, the patient census will look like. So census is essentially how many patients are actually in the hospital at any given time. And you can see on the lower left, we're projecting 655, a census of 655 on June 23rd as the peak. And on the lower right, a peak of 910 on June 5th. And actually, one thing is kind of important to point out here is that the the model that's being used here, which I'll get into in a little bit later, but the model that's being used here is not necessarily going to be accurate at like those longer time periods. And I'll get into the details of that later. And so, like, just briefly, we can talk about the type of model that is being used by CHIME and why we're using this model. So the type of model that we're using here is called an SIR model, and the S, I, and R stand for susceptible, infectious, and recovered. And then, so this is called this type of model is sometimes called a compartmental model. So each of these blocks is a compartment, and each of the it's a state-based model. So each state has a transition and sort of a formula that governs the transition between states. And so there's two parameters, this beta and this right here, the beta and the gamma. And so beta is essentially the infection rate or the rate of spread, and it's proportional to the size of susceptible and infectious. And then gamma is the recovery rate, which is calculated as 1 over the duration of infection, which you might remember from one of the previous slides was 14. So this is 1 over 14 in at least based off our assumptions. And you can see this transition only depends on the number of infectious patients. And so there's also another parameter called R, and that's calculated as beta over gamma, and so it represents like the relationship between this infection rate and the recovery rate, and that's sometimes called the basic reproduction rate. And then the total, if you sum up the S, the I, and the R, that equals your total population, so N. And so why use a simple model like this? So first of all, a SIR model, it's a standard epidemiological model. It's probably, I don't know, it is the simplest epidemiological model, but it is certainly one of the easiest and simplest epidemiological models. And so just a disclaimer, I'm not an epidemiologist. We actually worked with an epidemiologist on this work. And so it's a deterministic model, which makes it a little easier for us to analyze. It's easier to incorporate into a larger decision-making framework like we did with CHIME. So like calculating admissions and census, for example. We chose it because it was quick for us to develop, and it also has an intuitive clinical interpretation. And then another reason that we chose this rather than a more complex model, which might have more parameters, is there's so much uncertainty in all the parameters to these models. Even still, there's a lot of uncertainty. And so we wanted to, so by choosing a simpler model, we're limiting the amount of, at least the amount of uncertainty in those input parameters. All right, so what's next? Right, so these are, kind of the parameters that are on sort of like the front end. What are some like other parameters that impact the model? So there's this doubling time, which is actually this doubling time parameter, which is essentially the number of days for a case that it will take for a case, the number of cases to double. And so that's like, as you can tell, like that's directly related to that beta parameter in the first transition. And at least in the beginning, it looked like it was between 2 and 4 days based on what was happening at the time. There have been some other publications out there that put the number somewhere between 6 and 10. So it's like not entirely clear why there'd be like that big discrepancy, but one theory we have is that it might be because of the lag in time that it takes for confirmation, a case to be confirmed, which is not modeled by the SIR model. There's actually a more complex model called SEIR, which I'll talk about in a little bit, that tries to take that into account. And the one important like aspect of one reason the doubling time is really important is because this is one of the main components of sort of the exponential growth of these infections. Another important variable, which I don't think is actually being displayed here, is the market share. And so, or the market rate, so that's the market share of the hospital system. We know that what our current market share is. I think when we started off, we were told by our finance team that our market share was 15%, but this is under normal conditions. We don't know what will happen during a pandemic. For example, what happens if one of the other hospital systems in Philadelphia is over capacity? Then presumably those patients will have to come to Penn if we're not over capacity. And another important variable is hospital admission rate. This is based out of data, at least initially is based out of data out of China. And so one big question we have is, how will this be impacted by differences in care or admission standards between China and the United States? And there's obviously a high amount of uncertainty about both the value of the hospital admission rate and also the precision of that value. And then there's also hospital ICU and ventilator length of stay. So these were actually based off of internal numbers for ARDS patients, which stands for acute respiratory distress syndrome. And so we used that as our assumed length of stay for these patients, as opposed to published rates from other countries. And again, there's a lot of uncertainty in medical practices between regions. So that's why we chose our own numbers for that. And let's see what the next slide is. Oh, yep. So just briefly before I go on to the next slide, this is an example of what the CHIME tool looked like. I think it may look a little bit, it in fact does look quite a bit different than this now. So you can go to the website and check it out. But as you can see, it allows for the user to enter their assumptions in the left-hand side panel here, and then use this standard SIR model to project what the demand will be on the hospital. And actually, recently we published a paper on our use of CHIME, so I definitely recommend you go and read it. It has a lot of interesting details about how the tool was used at Penn and what the projections looked like at the time. And so before I move on to the next section, I just would like to sort of talk to you about other things that you might want to know about sort of the modeling of COVID-19. So, first of all, there's a lot of uncertainty around the disease. So there's a lot of data gaps. There are more sophisticated models, which might be more appropriate for later use in the pandemic. And in fact, in a little bit, I'm going to just talk to you about some more sophisticated models that we've been working on. We did some backfitting of the model on Penn's data to show that it seemed to be a pretty good fit for what was actually happening. And one important point about CHIME is that for the SIR model, there's closed form mathematical solutions to it, but we actually implemented a discrete time simulation, which is basically just a way of saying we're looping through the day by day to calculate that SINR on a day-by-day basis. And one reason we implemented it in kind of like the slow simulation approach was that we wanted, it made it easier for us to make modifications to the model as opposed to the closed form solutions. So for example, it like allows us to like customize that SIR model as we see the need for that. And some of the assumptions that are made by this type of SIR model, it assumes no seasonality, so no loss of immunity. It assumes heterogeneity of infection, so everyone has an equal likelihood of being infected. It does not account for the incubation period, and we focused on doubling time since this is the exponential parameter. There's a large variation in the outputs caused by uncertainty in the variables, especially doubling time, because of that's the primarily the exponential component, along with this amount of social distancing, which is like directly impacts that doubling time. And yeah, so I would definitely recommend you go read the paper if you're interested in CHIME. But next, I want to kind of dive into what we've done since we released CHIME. And so here's an example of our latest work. We're calling it Bayes CHIME, I think. And so what this does is that it builds on CHIME in a couple different ways. So first of all, we've been working on improving or using more complex models as opposed to just SIR. So we started off with adding an additional state. There's another standard variation on SIR called SEIR, where E is exposed. And so an SEIR model can account for the amount of time between someone being exposed to the virus and then becoming infectious. And so our first extension was to add this exposed state. And then we've also been working on, so I mentioned earlier that it assumes homogeneous, or had like equal likelihood of infection. It doesn't take into account, for example, people's contact networks. So there's some fancier models that take into account contact networks, and we've actually been working on integrating that sort of fancier approach into Bayes CHIME. And I think actually it is currently implemented right now. I believe that work is complete. And so we've added like the more advanced modeling. And then in addition to that, we've also brought this model, these kind of SIR models into this Bayesian or probabilistic framework. And so what this allows us to do is basically set some constraints on the prior distributions for each of the input variables, because one of the hardest parts about using CHIME is actually coming up with good estimates for what these inputs should be for these variables. So what we can do is we can leverage Bayesian modeling to try to try to take a data-driven approach to identifying what's the most likely distribution for these input variables to the models. And so that what that allows us to do is create these sort of posterior distributions for each of the variables, and also explore in a probabilistic way what the possible future trajectory of the disease will be. And so here's what you're seeing here is kind of an updated slide from the slides that are presented to the executive team. And so you can see on the top here, we're explaining what that these blue region at the top is the 90th percentile for the or the 90% credible region. And so what that represents is, of all the simulations being run, that's the 90th percentile on that particular day. And you can see the top of the orange region is the 75th percentile. And then the blue line in the middle is the median or the 50th percentile. The bottom of the orange region is the 25th percentile. And then at the bottom of the blue region, all the way at the bottom, is the 10th percentile. And then on the bottom here, you can see an example where we've put a dashed line for hospital capacity. And we can see in this example, we have 100 COVID bed capacity. It could meet the 75% of probable scenarios because it is just above that, the top of that orange region there, on around when that 75th percentile peaks. And then just to show you what this actually looks like for our downtown hospitals, this is from our forecast a couple days ago. And we can see that if you look at the median, it looks like, hopefully because of the social distancing, things are starting to flatten out. And if you're looking at the median, it looks like they may be flattening out. If you look at some, you know, say the 75th percentile, looks like we may still have a little ways to go. And so in the top left corner, we have the predicted hospital census on a day-by-day basis, and it looks like the median is going to peak sometime where around 220 patients at the median case. And in the upper right, we have the ventilator census, so that's peaking somewhere around 90 in the median case. And then on the bottom, we have the admissions the daily admissions, what the daily admissions look like. And so all of these projections still assume that an SEIR, or an SIR type of model is going to be able to predict or project the progression of the infection. It makes several assumptions. One is that social distancing will remain at the current level and not those like social distancing restrictions won't be lifted. We're actually in the process, I believe it may be done today or tomorrow, of adding in the capabilities to experiment with what will happen if social distancing restrictions are lifted, and so you can experiment with various policies around lifting social restrictions and see how that impacts these curves. And just to give you a little more insight into how this tool is being used. So basically, let me go into the GitHub repo here. Whoops. Let's see. So here's our GitHub repo. Feel free to check it out. It's public. And so we're Penn Signals / CHIME Sims. And there are basically two main scripts in this repository. This first one, _01_GOF_sims.py. So that runs the actual simulations, the Bayesian simulations. And then the second script, munge chains, creates the visuals that you saw. It also creates a couple other visuals, which I'll walk you through real quick. So, here's the primary visual that you saw before. This is actually projecting out to 200 days. And at least based on the assumptions that we're making, again, around social distancing not going away and the infection actually following this kind of model, it looks like we could see infections trailing off within 200 days. And you can, with these levels of uncertainty. And of course, these levels of uncertainty are only under the assumption that that COVID-19 is going to follow this kind of disease progression, that social distancing is not going to go away, and so on. We can also see we also can see this nice graph of what the model believes the effect of or the relative social contact, the what the relative social contact has been over time. So, the baseline being what it looked like before the crisis. And we can see that the model believes that somewhere around 15 or between 15 and 20 days in is when social distancing started to have an impact. The model assumes this is a logarithmic function, and we can see, here are the error bars around this function. And so it looks like at least the median is somewhere around 30% relative social contact. So that'd be a reduction of 70% of contact. And then the other handy visual that this tool creates is a visual of what the sort of the prior distributions. So these prior distributions, these blue distributions are the inputs are input into the model, and they constrain this posterior distribution. So this is the distribution of this parameter across the simulations. So the likely posterior distribution for these things. So you can see here is that beta parameter, the force of infection. Here's for the proportion of infections requiring hospitalization. So each of these is an input into the model. Proportion of hospitalizations admitted to ICU, proportion of ICU patients requiring ventilation, and hospital length of stay, ICU length of stay, coefficient on ICU length of stay, days from exposure to infectiousness, days from infection to recovery, logistic growth rate, logistic days from beginning of time series to middle, and the depth of social distancing. And so one obvious question that you might have about this sort of Bayesian approach is, how do I set good priors on these numbers, on these inputs? And so we have a Jupyter notebook that you can look at. This is in the notebooks directory of the repo. And so it kind of walks you through how would you inform your priors for this modeling. And so here's an example of how you can come up with a prior for social distancing. We looked at Google's COVID-19 mobility data. There's a bunch of other similar sources out there around that seek to try to measure the amount of reduction in mobility. And so at least initially, I think we've changed this since I created this notebook. But initially, we were assuming basically based off of this data out of Google that probably somewhere between a 25 to 45% reduction in social distancing. So we've built some functions where you can pass in basically those parameters, 25 to 45%, and it will output the parameters that you need to input into the tool, into Bayes CHIME, to set what that prior distribution is. And then a more complex variable to set is the average hospital length of stay. And so the way that I approached this was that we first built a survival model based on the actual length of stays for COVID-19 patients at Penn. And so, basically you need to create a data frame that has two columns. One is the length of stay, and then the second column is whether or not that patient was observed as having left. So whether or not that patient was discharged. And so then you can use standard survival models to try to model what is the actual length of stay for these kinds of patients. And so I've used a nice library called Lifelines. And so Lifelines has a bunch of different survival models built in. Kaplan-Meier, the simplest, it's a non-parametric model, whereas this Wavell fitter is a parametric model. And the reason that I use a parametric model is because I then am basically using this fitted survival model to bootstrap some samples, sample patients. So that's what's happening here. And I am sampling until the average begins to stabilize. So what you see being printed here is essentially what the average over time. I let it after about 2,000 iterations, these averages begin to stabilize. And then we can use this simulated data to come up with a distribution, a reasonable distribution for our hospital length of stay. All right, let's see if I have anything else. I think that might be it. Just one moment. So yeah, I think that's it for the slides. I just want to mention a few more things. So first of all, when we originally released CHIME, we were very surprised about the really huge impact that it had on our own executive teams thinking around the crisis. And so we worked basically through the weekend. This is like a month or so ago, and actually almost exactly a month ago, and pushed it out to the public and deployed it on the publicly available website, because we felt, since it had such an impact on our executives, that we need to get it out there so that other hospital systems could benefit from this kind of tool. And one thing that was extremely helpful, that we couldn't have done it without them, was we were able to get Code for Philly involved. And so Code for Philly took a very active role in both helping to sort of basically manage the heavy amount of load that we're seeing on the website. And also just there was, a huge number of volunteers that came in and helped clean up the code. And there were several people who found early on some bugs in the way that we were implementing the SIR model, or limitations, and helped address those. So we really could not have been as successful as we were without all that input from the community. And then just a few more minor comments before we go to Q&A. Let me bring up the tool. Let me bring up CHIME. So we built we built the original version of CHIME, and this is the current version of CHIME. We built it using this Python toolkit called Streamlit, and the original version was only 300 lines of code for the entire application, which is pretty amazing, honestly. I mean, I basically implemented we implemented the model plus this, simple interface in less than 2 days. And so, I mean, without this, the open source community, there's absolutely no way we could have possibly done this. And without the civic hacking community, we, as I said, we couldn't have done it either. And one thing that I've been asked is, why is this the first time that an approach like this has been taken? As there have been other pandemics in the past. How come we haven't seen these kinds of approaches being taken in prior pandemics? And I really do believe it's just a testament to the open source community that we can create these kinds of tools so rapidly, and the data science stack, and Python data science stack specifically. Yeah, I think that's it for my presentation. Do we want to move to Q&A?
All right. Thanks so much. That was really interesting. Can you hear me clearly?
Yep.
Okay, excellent. So got a lot of good questions coming through. Thanks for that presentation. So I'm going to try and group them together just to make it so that you can answer them in, sort of in logical sequence. So the first set of questions were about your sort of initial slides where you were looking at you're showing the numbers, admission, hospital admission, ICU admission, the numbers that go into the model. And the first question was So the new patient admission, hospital admission numbers that you put in there, are those specific for COVID-19, or is it any and all admissions?
So I assume the question was around this slide. That sounds logical anyway. So these are just COVID-19 patients that are being simulated here. And one thing to point out is that I mean, sure, there are definitely other types of admissions at Penn, but one of the early things that Penn did was they stopped elective surgeries, elective admissions of all kinds. So certainly a large majority, I'm not actually sure if it's a majority, but a large number of cases are at the hospital are COVID-19 cases at this point.
Okay. Then the second set of questions are around the model itself. So, and these may have been, you may have answered them in addressing the fact that there are more sophisticated models being applied. But the question was, does this model account for people who have recovered but then later get a positive result? Because that's been seen to happen in practice. Or is that accounted for in a completely different model?
Right, so it doesn't account for like loss of immunity. I mean, there's many possible explanations for a positive result after recovery, or like a negative result and then a positive result. It could be actually that the negative result was a false negative, for example. So the patient wasn't actually recovered, or it could mean that there's some loss of immunity, and these simple models don't take into account loss of immunity, for example.
And do they, that will probably answer the next question, is whether it would take into account the sensitivity and specificity of the diagnostic tests.
No. And I mean, one important decision we made for these models is that one of the main inputs into these models is actually the admitted patients at Penn. So let me pull up the tool again. So one of the most important inputs into this model is currently hospitalized patients. And the reason this is important is because there are lots of other ways that you could try to estimate the currently number of infected patients. But from a hospital's perspective, we have the most certainty around the actual number of hospitalized patients. So, an alternative to currently hospitalized patients, for example, could be positively tested patients. But as we know, there's all sorts of biases, unknown biases around testing. So we didn't want to use that as our way of estimating the number of infected patients. And there's like another popular model out there that actually uses death data out of China and Italy to sort of predict and project deaths in the United States. And death data also has all sorts of unknown biases. So if you're looking at death, if you're building a model off of death data out of China, for example, you have to wonder, are the numbers accurate for various reasons? Same with the numbers out of Italy, even out of the United States. You don't know that how accurate those numbers are. But from a hospital's perspective, we know how many patients are under our care that are currently suspected of having COVID-19. So for us, that we use that as like sort of to drive the estimated number of infections, because we have the most certainty around these currently hospitalized COVID-19 patients.
Okay, yeah, thanks. That makes a lot of sense. Then Chris wanted to know, how does your approach with CHIME compare with the resource estimation model being used at IHME, the healthdata.org?
Certainly. I mean, they're very different approaches. I sort of alluded to that in my previous response. So the IHME model assumes that it makes several different sets of assumptions. I mean, our model makes assumptions, their models makes different assumptions. So some of the different assumptions that model makes is, it assumes that deaths are going to follow a similar trajectory to China and Italy. And specifically, it assumes a level of social distancing equal to what was happening in Wuhan, China. And as we know, the degree and type of social distancing happening in the United States is not, or has a lot of differences than in Wuhan, China. And so that model is essentially a Gaussian, they're fitting a Gaussian curve to death data. So they're using the current death data in each state to project and they fit this sort of curve on Wuhan and Italy death data, and they're using that fitted curve to project based on the current death data on a state-by-state basis. What do we think the future death curve is going to look like? So given all those assumptions I already mentioned. And then they make some assumptions around resource utilization relative to death. So, you know, long story short, it's a very different approach. They're using like this Gaussian curve fitting method as opposed to a standard epidemiological model like SIR. SIR is, you know, a standard, SIR is a standard epidemiological model. And as our primary input is the current number of hospitalized patients as opposed to the number of deaths. And we feel that we have a lot more confidence in that input of current hospitalized patients versus death rate.
Okay, and then do you have any statistics on how many hospitals have used this model, and has it been successfully used outside the US?
Yeah, I mean, it's very hard for us to track exactly who's using the model except for those who have reached out to us. I don't think I can mention any specific hospital systems by name without their permission, but we've been contacted by people all over the world who are utilizing it. There are a lot of people there are a lot of hospital systems in the United States using it. There are also public health officials using it in the United States. I know that one of the more newsworthy use cases was the mayor of Washington, D.C. Used it in not necessarily not necessarily in the intended way, but it was being used by Washington, D.C. to project their needs.
Okay, and then there's a question here sort of regarding future plans. Are there plans to integrate Bayes CHIME into the main CHIME branches, or will it remain a CLI tool?
I think I think that's still a little bit up in the air. One main reason that the original CHIME is an interactive tool is because it allows people to kind of like explore that best case, worst case by hand, essentially, and look, and then in an interactive way. Whereas the Bayes CHIME kind of removes that need to sort of explore this space interactively. It like puts this Bayesian framework in place that to help come up with good estimates for what those inputs should be. And so in some ways, it removes that need for that sort of interactive tool. And secondly, running these simulations is actually very computationally intensive. And because of the way that these Bayesian simulations work, there's the MC process is very much serial. So it takes a lot of time. It wouldn't integrate well with an interactive tool. It is possible though that this second step, the step of building the visuals, we could potentially build an interactive tool around sort of the visualization of the results of the simulations. But I do, and certainly there's nothing stopping us from building some sort of web interface around this entire process. You could envision some sort of web interface where someone submits a job and lets the simulations run for a couple minutes and then comes back and looks at the results. But at least based on our own needs at Penn and sort of the needs of, I think, the more advanced users who are going to be using this Bayes CHIME, I believe that CLI is going to meet most users' needs.
I think that covers the questions that, there are some very specific questions here. I might let the think Chris has a question about potential parallelization. I might let him ask that question, but those were the main questions that came through the chat.
Excellent. Thanks, Mary. So Rama, do we want to open up for like more general Q&A? What's next?
嗰時我差啲去呢度做，但係怕 Madison 成高啦，你叫咗我 interview second round 呢個啲。
My own. Okay, if anybody has any questions, we can take that. We can, I can set it up so that you can unmute yourself. For now, just give me a moment and let me just set that. Just give me 1 second, please. Let me just allow. Okay. So I think you should be able to unmute yourself if you want to ask any additional questions. If anybody has any questions.
Michael, I have a very generic question that has to do with the graph that you saw at the beginning, about flattening the curve. The integral or the area below each one of the curves is the same?
I mean, it certainly depends, I suppose. Not necessarily is, I think, the answer to your question.
Could you elaborate a little bit on that?
Sure. So by social distancing, it's possible that some people may not get infected who would have previously gotten infected. You know, maybe. I mean, I think in that very simplified graph, I believe that the intent is that, you know, the same number of infections happen, but I think in reality, that may not be the case. In reality, we may get, you know, some people may become hermits and never leave their houses and never get infected, or, you know, maybe we are able to lower the infection rates some other way down the line. Whereas if, you know, just by delaying infections, maybe there's some mitigation strategy that can be put in place that will prevent people from becoming infected who would have otherwise become infected.
So just as a follow-up, I mean, do you think there will be a second hype or a second curve if those people that hibernate or wait at home will get out eventually, and then we'll start a second wave?
I mean, it's possible. It's impossible to predict, of course, but yeah, certainly possible.
Mike, could I ask a question?
Yeah, sure.
I'm someone who is looking at what the governments are saying and loosening restrictions, maybe within a month and all this. And on some of the charts you were showing what looked to me like we're going to be lucky if we manage to keep below capacity out through the middle of the summer.
Here, let me pull up the graph so we can just look at what you're talking about.
I'm looking at this on like on a small mobile device, so it's a little hard to tell, but.
Oh, sure. So,
I was just wondering, like.
Go ahead.
I'm assuming the charts, the graphs you're doing now are based on the current level of sheltering in place?
Exactly. So let me see if I can make this big enough for you to be able to see on your phone. But we're assuming this sort of logarithmic curve for the social contact, which implies that the social contact does not increase past,
Right.
you know, after this point. So as I said, we're working on adding in the functionality into this sort of Bayesian modeling that will allow us to experiment with what could be the possible effects of loosening social distancing over time. For example, you know, if you loosen social distancing by X percentage in this number of days versus, you know, in 10 days versus the same thing in 40 days, how does that impact the overall number of infections? Because one thing to keep in mind is that there's this kind of concept of herd immunity. After a certain percentage of the population has been infected, it provides this kind of herd immunity to the rest of the population. So there is, potentially there are potential strategies where they could loosen the social distancing restrictions, and so you can use this Bayesian framework to kind of experiment with those various strategies.
Well, I think my real question was, at the current levels of shutdown, I thought I was seeing you projecting out into June, at least into June, that you're going to have significant admission rates.
Yep. That's what we're looking at. I mean,
I'm hearing people say we're not going to really be able to really loosen social distancing restrictions until we have a vaccine, which is like at least a year away.
Yeah, so there's a lot of assumptions being made here. One is that immunity to, like, once you've been infected, you won't be reinfected, which we have no way of knowing if that is true or not.
Right.
And there's some other assumptions being that are also being made, but like that's the primary assumption. So if it turns out that your immunity is not sustained, like say this becomes like a seasonal type disease like the flu, then like these kinds of models are wrong, obviously wrong.
Right. Yeah, I know the purpose of your model is not to tell me whether I'm going to die. It's to figure out whether you have enough beds for me to die in. And so,
yeah, I mean, the primary usage of this model is just to like help us plan on very short time horizons. In fact, our epidemiologists would very much cringe at us even projecting out this far, because these types of models have never really been used that way, and there's no way to like know. I mean, as you can see, there's very, very high levels of uncertainty around, like, when you're looking out into like the June, July timeframe, we're talking about very huge error bars in these projections.
Right.
So, while it's reassuring that the median value for the hospital census looks like we're nearing a peak, if you look at the 90th percentile or the 10th percentile, it's hard to say which of these scenarios we're actually in, especially given that we're not really predicting the future here, right? We don't know what's going to happen with the social distancing going forward. There's so many unknowns, but what this type of tool does provide is it allows us to look into like the short-term time frame and plan around what we need to do at the hospital to make sure that we have enough resources for the worst case scenario.
Yeah, this is great. Thank you so much.
You're welcome.
Hey, Mike, before you leave that screen, there was actually a question that came through earlier, and I was not sure what curve, but I believe it's this curve. So the question was, there's a bit of a downturn in the prediction just around April, so of those first few days of April. What could that be accounted for? What's the meaning of that?
Sure. So we believe that this is like the initial effect of the social distancing. I mean, again, this assumes that the disease follows this like SIR model, which, again, we won't know until after the fact if it actually did follow this kind of SEIR model. But under those assumptions, it looks like the social distancing is going to cause an initial drop off, but because there's so many susceptible patients still out there, the social distancing will not be enough. In at least the median case, the social distancing will not be enough to prevent a second peak. However, you can see there are scenarios where the trajectory is actually completely downward from here. So, but under the assumption that we're in this median area of the space, it's very possible that there will be a second peak.
Thank you.